So, a very good evening, everyone. In continuation to our efforts in disseminating science, we are here with the fourth module of ISGU and the last module for the year, covering the muscle invasive bladder cancer approaches as well as its treatment. In the first three modules, we have disseminated science on prostate cancer as well as non-muscle invasive bladder cancer. Over here, we are going towards the advanced cancer, that is the muscle invasive bladder cancer. So with this, I would like to invite Dr. Chirag Desai to speak upon muscle invasive bladder cancer, covering the epidemiology, treatment options, and the future prospects. So sir, may I request you to share your screen and begin with the session.
I hope my screen is visible.
Yes, sir.
Yes, sir.
Wonderful. So good evening, everyone, and thank you, Ritika. Thank you, Dr. Abhijit, for inviting me to speak on muscle invasive bladder cancer. In next about half an hour or so, what I intend to do is to learn and discuss about MIBC, currently available treatment and the guidelines and the future perspectives of treatment of MIBC. So this is the outline of my presentation. Little introduction and epidemiology, maybe a couple of minutes, and then classification, symptoms, diagnosis, treatment guidelines, and then finally a summary of what we are doing in 2023. So we know that bladder cancer remains the most common malignancy of urinary tract, and in 2018, bladder cancer was diagnosed in 5.5 lakh patients world over, and almost 2 lakhs of these patients succumb to this disease worldwide. Among bladder cancer, transitional cell carcinoma, now it is called urothelial carcinoma, is the most common cancer. Tumor that invades detrusor muscle is termed as MIBC, and that's what we are going to discuss today. If we talk of Indian data in Globocon 2020 database, bladder cancer is a common malignancy in India. The 5-year prevalence rate is approximately 3.57 per 100,000 population, and it results in about 11,000 deaths every year in our country. So a significant problem, much common than many other cancers. So if we look at the proportion of various stages of bladder cancer, non-muscle invading that was discussed last time, almost 3/4 of them are NMIBC at presentation. Some of them down the line do progress to MIBC, and the intention of treatment in NMIBC is to ensure that the patient do not progress to MIBC. About 20 to 30% out of 100 present with MIBC, and almost 5 to 10% of the patient present with metastatic bladder cancer. So some of the patient with MIBC ultimately will end up having a metastasis and will be treated as per the guidelines of metastatic breast cancer. I'm sorry. Breast cancer is something I discussed over last 3-4 days. So breast cancer is in my mind, but we are discussing bladder cancer. So these are the risk factors, and I'm not going to discuss about the risk factors. Cigarette smoking is one of them. This slide was included just to complete the slide set. So how do these patients present to us? In the early stages, change in the bladder habit, increased frequency or urgency of urination, or pain or irritation during urination, and nocturnal urination is the sign of initial bladder cancer. And when the patient has more advanced bladder cancer, they present with pain due to obstruction in the upper urinary tract, typical urinary colic, or maybe inability to urinate because of the obstruction because of blood clot, pain in the lower back on one side, appetite decrease and weight loss, fatigue, edema, fit, and bone pain because of the metastatic disease. So 85% of the patient do have gross hematuria, and maybe 15% of the patient may have microscopic hematuria. And because of the health checkup, they may have picked up the presence of bladder cancer. So this is in nutshell the symptomatology of this patient. After the symptoms, medical history and physical examination, patient usually undergo imaging studies, and in our country, the first imaging study usually is an ultrasound. followed by some basic lab tests, cystoscopy, and biopsy. And this leads to the diagnosis of bladder cancer. So this is a graphic representation of what do we mean by in situ carcinoma TA, T1, T2, and T3. So the tumor limited to the urothelium only is either CIS or TA. Invading the lamina propria is T1. And what we are going to discuss today is T2, T3, and what is not mentioned over here is T4. So TNM classification, TA, TIS, and T1 are NMIBC. T2 is invading the muscles. T2A is superficial muscle. T2B is deep muscle. T3 is in perivesical tissue. And T4 is the involvement of the organs surrounding the bladder. It may be T4A or T4B, depending on what is the extent of invasion to prostatic stroma, seminal vesicle, uterus, or vagina. For T4A and pelvic wall or abdominal wall is T4B. For lymph nodes, N0 is no node, while N1 and N2 is single or multiple regional lymph nodes in true pelvis, while N3 is metastasis in common iliac lymph nodes. M1A is lymph nodes only, but no regional lymph nodes, and M1B is elsewhere in the body, distant metastasis. So this is the stage grouping, and we are not going to discuss NMIBC at the top of this chart and MBC on the bottom of this chart. What we are going to discuss is stage 2, 3A, 3B, and 4A. There is T2 to T4, N1, N2 or N3, or maybe even N0. So this is from NCCN. And what I want to highlight here is that when we suspect a bladder cancer, I think the first thing that we need to do is to do an imaging of abdomen and pelvis. I will let you know why we should do it first. Before going for cystoscopy and the biopsy, we need to go for the abdominal pelvic staging. And what sort of staging I will show in the next slide. The reason is, if we do the biopsy, if we do the aggressive TURBT, patient may have the edema in the bladder wall, and that may interfere with the exact assessment of T staging of these patients. And once staging is done, examination anesthesia, TURBT. At the time of TURBT, we often recommend administration of single dose of intravesical chemotherapy within 24 hours of TURBT before the report of pathology comes. It may be either gemcitabine or mitomycin. And we need to do the imaging of upper tract, because some of these patients may also have the involvement of upper tract, renal pelvis or ureter. So if we do only PET CT scan, as we are fond of nowadays, because of the availability of PET CT scan at a very cheap rate all across the country, we have the temptation of doing PET CT scan, assuming that it is the one-stop solution for all sort of imaging. But that is not true. I believe CT urography that delineates the kidney, the renal pelvis, as well as ureter in addition to the bladder very well. It has to be done. If the patient is sensitive to the dye, or if the patient's renal function is not permitting, we can do MR urography. But the urography has to be performed for the staging of bladder cancer. MRI in general is a good investigation for T staging, while CT scan or PET CT scan is a good investigation for nodal staging. If you do the FDG PET, it's a good investigation for finding out the metastasis elsewhere in the body. We usually don't perform PET CT scan in T2 or earlier urological cancer. So if initial diagnosis was NMIBC, this must have been discussed in the last discussion, but I will highlight a couple of points in NMIBC before jumping on to the MIBC. Look at the bottom right-sided corner of this slide. If there is high-grade NMIBC, if it shows the carcinoma in situ or TA, we don't need to do anything else. But if it is T1 or selected cases of TA, we need to do repeat TURBT. And if the initial TURBT was incomplete, if there was high volume disease, or very often, as happens in our country, if it was not done by a uro-oncologist, if it was done by a general urologist, I think we need to repeat TURBT. For the completion of TURBT, and if that repeat TURBT shows NMIBC, then we should follow the NMIBC treatment as it was discussed in the last meeting. And if it is MIBC, treat as MIBC. The advantage of repeat TURBT is it improves the recurrence-free survival, progression-free survival, and overall survival. It often upstages the tumor to MIBC, and this happens in as many as 20% of the cases, and the management is different altogether. There are several articles, several publications, and I have shown just one of them. The 10-year extension trial of 210 patients with PT1 NMIBC, those who underwent repeat TURBT and those who didn't. So those who underwent repeat TURBT had significantly higher 5, 7, and 10-year relapse-free survival and progression-free survival. And in addition, 10-year overall survival was significantly higher in these patients, 59% versus 40.8%. So repeat TURBT was found to be an independent determinant of improved overall survival in multivariate analysis also. So in these cases, as I've shown, repeat TURBT has to be done, and some of them may turn out to be MIBC. Now, when MIBC is confirmed by the pathologist, we need to complete the staging evaluation with complete blood count, chemistry profile, chest imaging, bone imaging. We can replace chest and bone imaging together in a PET CT scan if it is not done already. And then what we are going to discuss in next about 20 minutes is the management of stage 2, 3, and 4A. We are not going to discuss metastatic urinary bladder cancer. So treatment is usually neoadjuvant therapy followed by radical cystectomy along with pelvic lymph node dissection. There are various modalities of urinary diversion, which I will just briefly touch upon. I will not be discussing in great detail urinary diversion because that's a hardcore surgical topic. I will be discussing about the bladder sparing protocol as well, such as chemoradiation or partial cystectomy in selected patients. So let us first discuss about why chemotherapy is important. And this audience, I believe, is predominantly medical oncologists and residents in medical oncology. Do not need to highlight the importance of chemotherapy, but still, I will briefly touch upon this topic. So this slide shows that in US, 5-year survival rate of bladder cancer is 77%. In Europe, overall, it is 72%, ranges from 57% in Slovenia to 78% in Germany. And in Asian countries, in Thailand, it is 48%, in India, it is 39%. It is slightly older slide, but it highlights that we need to do a lot to improve the outcome of these patients. Adjuvant chemotherapy, there are multiple trials. And most of these trials are small trials ranging from 49 to 102 patients. This one trial was published in 1991 when I started my oncology training. And it showed that median survival was 4.3 versus 2.4 years with chemotherapy and without chemotherapy. And the chemotherapy here was cisplatinum, doxorubicin, and cyclophosphamide. But 91 patients out of 498 patients who were screened were eligible. So it was super selective, 91 patients. So it was the criticism of this trial. Another trial published in 1995 and then updated in 2006. Again, it was terminated with only 49 patients enrolled, but showed a very significant improvement in the progression-free as well as overall survival. There are several negative trials, and if you look at the meta-analysis, 9 randomized control trials, see, all these trials had a small number of patients. This was published in 2013, and out of 9 randomized control trials, 945 patients were there. OS pooled hazard ratio was 0.77, just significant. DFS was significant at hazard ratio of 0.66, and you can see the diamond of the overall is far right, far left from the line of unity. Then why neoadjuvant? Why not just adjuvant therapy? Because there are several neoadjuvant therapy trials with a larger number of patients and more definite improvement in the overall survival. European trial, 967 patients, CMV versus no chemotherapy. 7 years follow-up showed significant improvement in the overall survival as well as PFS. But some of these patients underwent cystectomy, some of these patients underwent radiation, and there was no subgroup analysis of those who underwent cystectomy versus radiation. American trial, 317 patients with T2 to T4A disease, 3 cycles of MVEC chemotherapy versus no chemotherapy. At 3 years, 77 versus 46 months, 3 years gain in the survival and decreases of breast cancer specific mortality, improved OAS by 5%. And then there was a meta-analysis of 2,688 patients showing improvement in the survival by about 5%. Canadian meta-analysis, survival improvement by 6.5%. And then one more meta-analysis with 3,000 patients, OS improved by 5%. So robust data for neoadjuvant therapy, showing that neoadjuvant therapy should be given. And if you look at the Indian literature, this is the article from the group from Tata Hospital. It shows that in spite of high level of evidence, chemotherapy is underutilized. Concern from the neurosurgeon regarding the delay is, I would say, hypothetical concern because that rarely ever happens. Delay in the initiating of the definitive treatment and worsening of the survival thereby, that usually doesn't happen. Half of the patient may not be eligible for cisplatin chemotherapy and they may not be eligible for neoadjuvant chemotherapy. And the reason may be because of advanced age, because of the poor performance status, because of high creatinine and so on and so forth. But in spite of survival advantage, NACT is given to 15 to 20% of our patient. This was in 2018, and I hope that the numbers have improved currently. And if the patient is not eligible for cisplatinum, patient may be given carboplatin and gemcitabine based on the retrospective data. However, level 1 evidence for this situation is lacking. So I will recommend that patient should not be given neoadjuvant therapy if the patient is operable and is not suitable for cisplatinum. So why neoadjuvant and why not adjuvant? First, because of the robustness of the data in neoadjuvant setting as compared to the adjuvant setting. Patient is intact when the patient is receiving neoadjuvant therapy. Very often we are seeing the delay in the recovery in the post-op period, and we are not able to start chemotherapy for about 3-4 months, and that will dilute the improvement by the adjuvant therapy if neoadjuvant therapy is not given. If the patient has upper tract involvement, patient may require nephrectomy resulting in poor renal function, and patient may not be eligible for cisplatinum post-operatively. And post-op complication with chemotherapy are slightly higher. And we all medical oncologists can safely administer neoadjuvant chemotherapy and hand over the patient intact to the surgeons so that they can do their surgery safely. And there is no increase in the post-operative complication after neoadjuvant chemotherapy that has been observed in a large number of clinical trials. Now let us look at the guidelines. So this is the complicated NCCN guidelines. T2 and 0. Remember, I used the word complicated NCCN guidelines. I will explain you why I said it is complicated NCCN guideline. So after adequate staging, adequate workup, patient should be offered neoadjuvant cisplatinum-based chemotherapy. I will come back to this issue, cisplatinum-based chemotherapy, and what do I mean by that? Followed by radical cystectomy. And in very selected patient, we may go for partial cystectomy after neoadjuvant chemotherapy. Based on the pathological risk, we can offer further adjuvant therapy. If the patient did not receive neoadjuvant therapy, patient should be offered cisplatin-based chemotherapy as adjuvant. And if the patient has residual tumor, we may offer nivolumab to these patients. If the patient is not eligible for cisplatin-based chemotherapy and undergone cystectomy, then we can offer nivolumab to that patient as well. And radiation in very selected patient, maybe T3, T4 positive nodes or margins, this patient may be eligible for adjuvant radiation. But in general, we don't offer adjuvant radiation to most of our patients. If cystectomy alone, if the patient is not eligible for cisplatin-based chemotherapy, but this should be followed by nivolumab as per the current literature. Bladder preservation with concurrent chemoradiation may be offered to selected patient and reassess the tumor status after 2 to 3 months of completing of the treatment. If there is no tumor observed, if there is tumor present, if it is non-muscle invading, offer intravesical therapy. If it is muscle invading, go for surgery, or maybe you can treat it as metastatic disease. And non-cystotomy candidate, radiation or TURBT only reassessed after 2 to 3 months. No tumor, just observe, and if the tumor is present, if the patient is not candidate for further treatment, just treat like metastatic disease. If it is advanced T3 or T4 or maybe N1 disease, after initial staging, go for neoadjuvant chemotherapy like T2. Bladder preservation is usually not possible for more advanced disease. And if the patient had residual disease after neoadjuvant therapy and cystectomy, offer nivolumab. Non-cystectomy candidate, concurrent chemoradiation is to be given, reassess after 2 to 3 months. And if there is tumor present, go for further systemic therapy or TURBT or cystectomy if the patient is eligible at that point in time. So it was complicated American NCCN guideline. European Association of Urology has tried to simplify it. Diagnosis by cystoscopy and tumor resection, evaluation of urethra, CT imaging and MRI imaging, C2 to 4, N0, M0. Maybe selected T2 N0 may be offered trimodality treatment, bladder preservation. And for most of the patient, it is neoadjuvant chemotherapy. Cisplatinum fit patient, and there is 5 to 8% survival benefit. Radiation therapy is not recommended, and immunotherapy is experimental only in the clinical setting in neoadjuvant. I will show a couple of references for neoadjuvant chemoimmunotherapy. And further following down from this slide, radical cystectomy, no general aspects of surgery, preparation, surgical technique, integrated nodal dissection, urinary diversion, timing of surgery, and the centers with higher case load have a better outcome. Adjuvant systemic therapy, immunotherapy in selected patient, I just said that, and considered chemotherapy in selected patient if neoadjuvant was not given. So this is a simplified version of complicated American guidelines. Going back to NCCN guidelines for more advanced nodal disease, the primary treatment is downstaging by systemic therapy, and usually it is cisplatin, gemcitabine, or maybe MVEC. If there is complete response, consolidate the response by either surgery or chemoradiation. If there is partial response, again, cystectomy or chemoradiation, or maybe if the patient is not fit enough, treat like metastatic disease. If there is progression, treat like metastatic disease. And if the initial treatment is concurrent chemoradiation, complete response, just follow the patient. If there is partial response, if there is an MIBC, offer intravesical therapy or surgical consolidation if there is more advanced disease, and on progression, treat like metastatic disease. So these are the treatment guidelines as available to us. So this is a relatively busy slide, but I will show the important points in this slide. Cisplatinum is essential component in neoadjuvant therapy. Gemcitabine plus cisplatinum or dose-dense MVEC are the treatment options that should be offered to the patient. Now, gemcitabine cisplatinum, we don't have systematic randomized large controlled trials either in the metastatic setting or in the neoadjuvant setting, and it is the extrapolation of the comparison of MVEC with cisplatin gemcitabine showing equivalent efficacy and better safety. So it is an extrapolation that we are taking. And we have a trial in metastatic setting of DD-MVEC versus MVEC showing that all parameters of outcome are better with DD-MVEC. So in the neoadjuvant setting also we are preferring either cisplatin gemcitabine or dose-dense MVEC. Now there is a randomized clinical trial of perioperative chemotherapy with DD-MVEC versus gemcitabine and cisplatinum, and this was presented in ESMO 2021 conference. So this was a study design, neoadjuvant or adjuvant, and most of the patients received neoadjuvant therapy, 6 cycles of dose-dense MVEC Now it was 6 cycles, and cisplatin gemcitabine was 4 cycles. But DDMVAC was 2 weekly, so it was administered in 3 months, while gemcitabine cisplatin was 4 weekly cycles, rather 3 weekly cycles, 4 cycles. So it was administered in 12 weeks. So total duration was nearly same, 12 weeks, 12 weeks. So it was observed that the primary endpoint 3 years PFS rate with DDMVAC was 64%, while it was 56% in gemcitabine cisplatinum. It is all across the population, all patients put together. If you look at only neoadjuvant, the difference was of 10, 66% versus 56%. And the hazard ratio here was 0.7. And hazard ratio for overall survival in the intent to treat population, neoadjuvant as well as adjuvant, was 0.74, where it was 0.66 for neoadjuvant group. So the conclusion was that DDMVAC was having superior outcome in all the measures. OS data was still immature at that point in time. So I will want to switch to DDMVAC soon. I have not yet, but in the next patient, I think I'll be switching to dose-dense MVAC. So what about neoadjuvant immunochemotherapy? It is experimental, one line. A number of trials are ongoing, and I will show representative trials, a couple of trials where we don't have the data. So Niagara is a phase 3 trial evaluating neoadjuvant durvalumab with gemcitabine cisplatinum, followed by adjuvant durvalumab. So with or without durvalumab are the two treatment arms, and the primary endpoint is pathological complete response and event-free survival. And likewise, look at the bottom paragraph. Neoadjuvant systemic immunotherapy with pembrolizumab has shown the promise in a prospective single group phase 2 trial of 50 patients with MIBC, with 42% of the patients achieving pathological complete response and 54% downstage to T1 or lower disease. So exciting, but just 50 patients. So time is not yet right to switch to neoadjuvant immunotherapy or neoadjuvant chemoimmunotherapy. So after neoadjuvant therapy, patients should undergo radical cystectomy. And by radical cystectomy, what we mean is it involves the removal of bladder, prostate and seminal vesicles in men, and uterus, fallopian tubes, ovaries, and anterior vagina in women. Lymph node dissection is essential during the curative intent radical cystectomy, and it is supported by AUA, EAU, and NCCN with variable strength, but lymph node dissection has to be done. Now, I have discussed with so many urologists, and they are usually reluctant to offer the lymph node dissection, and they don't do any dissection of lymph nodes in kidney cancer, and they just do the sampling in bladder as well as prostate cancer, but it has to be more elaborate as per my understanding. And systematic review reported on 7 studies with more than 13,000 patients showed an increase in the 5-year survival rate because of the performance of meticulous lymph node dissection. So that's important. And urinary diversion, again, this is a hardcore surgical topic, but the ileal conduit is made. The ureters are implanted in that conduit, and either this ileal conduit is the anastomos to the urethra if that is possible, so that patient can have the natural voiding through the urethra, or patient may be given a stoma outside, and each of these two approaches are having their own advantages and disadvantages. In clinical practice, more than 80% of the patient undergo ileal conduit urinary diversion, given the fragility of patient population because of elderly population, the relative familiarity of this operation to the majority of urologists and potentially reduce frequency of post-operative complications. So that's how it is. And for radical cystectomy, patient selection is any MIBC patient requires radical cystectomy. The clinical outcome is 50% cure with surgery alone, and it is highly dependent on the pathological stage. We can improve this outcome with neoadjuvant as well as adjuvant therapy. Bladder sparing partial cystectomy, solid tumor in the dome of bladder are ideal. Occasional patient, I will not recommend in most of the patient. Bladder sparing chemoradiation, I will show that in the next slide. neoadjuvant cisplatin-based chemotherapy should be given to all cisplatin eligible patients, leads to 5 to 10% improvement in the overall survival as compared to cystectomy alone. And adjuvant therapy is likely to have similar improvement in the outcome, but the data is less robust as compared to the neoadjuvant therapy. So there are a number of complications. I think we will skip this slide for the shortage of time. And there are a number of bladder sparing approaches, a regimen of maximal TURBT. So that's very important. When we are offering the trimodality treatment, we have to ensure that the patient does not have any residual tumor in the bladder at the time of offering the treatment. By radiosensitizing chemotherapy and radiation, dubbed trimodal therapy, it is an alternative to cystectomy in T2N0 patients. And chemotherapy used in TMT is often the combination of cisplatin with either 5-FU or paclitaxel or 5-FU with mitomycin C, or maybe cisplatin alone, and maybe low-dose gemcitabine, all various options. So there is a wonderful article. There are a number of articles discussing this particular approach. One of the latest articles was published in June 2023 in Lancet Oncology, radical cystectomy versus trimodality therapy for muscle invasive bladder cancer, a multi-institutional propensity score match and weighted analysis. So this was not directly randomized trial, but it was the match with the historical control. And the interpretation here, I can share the full-length article. Just drop an email to me, chiragdesai.oncology@gmail.com. The interpretation or the conclusion of trial was that this multi-institutional study provides the best evidence to date, showing the similar oncological outcomes between radical cystectomy and trimodality therapy for select patients with MIBC. These results support that trimodality therapy in the setting of multidisciplinary shared decision-making should be offered to suitable candidates, all suitable candidates with MIBC, not only to the patient with significant comorbidities for whom surgery is not an option. So this is an important finding from this trial. So treatment of MIBC is a teamwork where urologist, pathologist, pharmacist, radiologist, medical oncologist, urology surgeon, urology nurse, as well as the diagnostic radiologist, all work together to ensure the best outcome to this patient. So MDT approach in MIBC enables integrated care. The standard of care treatment approach for most of the patients with MIBC is neoadjuvant cisplatin-based chemotherapy, radical cystectomy, and extended lymphadenectomy. Approximately half of the MIBC patients may not be eligible for cisplatin-based neoadjuvant chemotherapy, usually because of their advanced age or poor performance status or renal impairment. There is currently no standard of care adjuvant therapy for this patient. However, adjuvant nivolumab can be offered because of the publication, good outcome in this publication. The result of survival is still immature, but in high-risk setting, nivolumab can be offered. Radiation or chemotherapy may be used in select patients who are eligible or would prefer bladder-preserving therapy or for palliative care. And current guidelines from major societies are generally similar, widely used in the setting of MIBC, and provide consistent recommendation for the treatment of this patient. So thank you very much, and I will be happy to answer any question, or maybe we can start with the panel discussion. Thank you very much.
Thank you so much, sir, for such a wonderful presentation. I think all the aspects have been covered, and we have Dr. A.K. Ved also with us now. So, sir, thank you so much for joining, and maybe a few words because you were not there for the opening remarks today.
That was a great exposition. I think only Chirag could do it, and it's been a great lecture. Chirag, let me compliment you on the time taken and really educational. You talked about the surgical aspects. It's very unusual for medical oncologists to talk about surgical aspects in the lectures. It must have taken you some time to put up all this, and I'm sure the students would have benefited immensely. So your point about the MRC trial, talking about the NACT versus adjuvant, was spot on. I think all students and all young oncologists must take this message that the muscle invasive tumor is not a medical oncologist disease. It's a multimodality disease, and your algorithm for treating T2 to T4A was spot on again. And the point that chemo has been underutilized is again a strong point, and we need to work with our urology friends to sort of propagate the message more, so that more and more patients derive benefit out of this. And the benefits that in the preoperative setting, when we are using chemo, so many benefits you elucidated, they are very, very spot on again. And the tri-modality being better in muscle invasive, again, should go as a very loud message. And I again compliment you for this. Ritika, thank you so much for organizing such wonderful lectures time and again.
Thank you so much, sir. I think Dr. Chirag, Dr. Atul, Dr. Nagendra, and of course the students have taken a lot of efforts to prepare the presentations, and they have said yes to the lecture and joined in time. So
My
that
sincere thanks to others as well, not to
yes,
sort of undermine others' efforts. This was only with reference to Dr. Chirag's lecture,
yes,
but I'm
yes,
indeed really impressed and grateful to all of them, everyone who comes on this, and especially the students. They bring their
yes.
cases, discuss, and they have the opportunity to interact with the senior faculty. Thank you so much for creating this platform.
Absolutely, sir. So I would also like to request audience to keep on posting their questions. I know the questions mostly comes after the case-based discussions. So please keep on posting your questions in the chat box and we can take up the questions. So with this, I would like to invite Dr. Atul Batra now for the moderation of the session. And we can start with our student. First, Dr. Archana Sasi for her case presentation.
Good
Ma'am,
evening.
you can, yes, ma'am. Please see if you can just share your screen. Yes.
Is my screen visible?
Yes, ma'am. It is. It is. So we have a panelist, Dr. Chirag Desai, Dr. Vaibhav Chaudhary, and Dr. Nagendra Sharma today with us. After her presentation, we'll directly jump on to Dr. Athira's presentation. So, ma'am, over to you.
Okay. Good evening to everyone present here. It's a great opportunity to be able to present this case here. And I'm Dr. Archana Shashi. I'm Senior Resident in Medical Oncology, the All India Institute of Medical Sciences, New Delhi. And the moderator for this presentation, as Ritika had mentioned, is Dr. Atul Batra. So we have a 66-year-old male who presented to us. He was a resident of Delhi and a retired shop owner, a never smoker, and with comorbidities of hypertension and diabetes. So he presented to us with complaints of frequent urination and hematuria for a duration of 2 months. On examination, he was quite obese with a BMI of 39, with a performance status of 0. The rest of the systemic examination was normal. On his initial basic evaluation, because of the hematuria, we got a urine cytology done, which showed some atypical cells. And we got his routine lab work done as well. And this showed an elevated serum creatinine of 1.4 milligram per deciliter, giving us a creatinine clearance of 54 ml per minute. And the remaining labs were essentially normal. We went on to get an initial imaging evaluation done for this patient with a multiparametric MRI, and that showed the image that you can see here. And then this patient went on to receive a transurethral bladder transurethral resection of bladder tumor, which the pathology of which showed urothelial carcinoma with focal squamous cell differentiation, and there was invasion into the muscularis propria. So we thought about what would be the best therapy to go ahead with for this particular patient based on the presenting profile. And ultimately, following discussion with the patient and with his family, the patient went on to receive trimodality therapy with concurrent cisplatin etoposide-based radiotherapy. At a follow-up of 3 months, there was no residual disease on his CT chest and abdomen. However, he continued to follow up with us, and at 9 months, a CT done showed recurrence in the posterior bladder wall. And there were also enlarged common iliac nodes bilaterally. A PET scan done for staging did not show any distant metastasis. So, following this, the patient went on, was taken on by the urology team, and a radical cystectomy was performed. The postoperative histopathology showed P3N3 disease, and following this, the patient was given adjuvant nivolumab from the medical oncology team for a duration of 1 year. As of now, he has followed up with us for a subsequent 1 year, and he has been disease free and is doing well currently. So I hand over to Dr. Batra for the panel discussion.
Thank you, Archana. Ritika, do we do it now or after both the cases? How do we go about it?
Sir, as you wish. Usually we discuss one case and then go on to the second case. So we can.
Okay, so maybe we can discuss the first case. So Archana, can you put up the slide? We could have discussed then from the beginning. Can you share the screen again, and then we can go over the relevant points of discussion from the beginning?
Yes.
And good evening, everyone, and thank you for inviting me to this session. So, so to begin with, this patient presented with hematuria and was found to have, he's a 66-year-old gentleman. So if this patient was discussed in the tumor board, if I can ask maybe to begin with Dr. Vaibhav, so how do you, if this patient was supposedly asked to treat with a neoadjuvant chemotherapy approach, how do you decide on the cisplatin eligibility, and what are your, go-to criteria? Do you depend on creatinine clearance and estimated GFR, or you do a DTPA scan?
Actually, we go by the GALS criteria, and as far as that goes, GFR of 60 is the cutoff. But since this is the thing where
you consider between 50 to 60
exactly
as a borderline,
and we can actually work on it and make it 60 by actually hydrating the patient, and sometimes between 50 to 60 also we are actually inclined to give cisplatin-based neoadjuvant therapy. So that's not a hindrance here. Another thing would be the comorbidities like grade 2 auditory loss, or some kind of peripheral neuropathy patient has, NYHA class 3 of heart failure, and overall ECOG performance 2 or more. So these are the things which are actually universally accepted, which we decide to go in for cisplatin base. So he seems to be borderline, but might be fit for it.
Okay. Do you go ahead and do a DTPA scan, or you are okay with the serum creatinine of 1.4?
Basically, when we do the GFR calculation by Cockcroft-Gault, we actually underestimate GFR, not overestimate it. So when this is so borderline, Cockcroft-Gault is good enough for us.
Okay. Dr. Chirag Desai, good evening, sir. Sir, anything that we generally tend to do a routine DTPA scan in patients where we see this borderline kind of stuff, and we have seen, although it tends to underestimate, but we have seen either side, and we tend to kind of rely more on those scans. Dr. Chirag Desai?
I think I will go ahead with this report only, and as Vaibhav rightly said, try to optimize the patient by improving the hydration if the patient is infected, by treating the infection, and so on and so forth. One difference that I do in my practice is with borderline GFR. I split the cisplatin in day 1 and day 8 rather than a full dose of cisplatin day 1. So that's my take.
Right. Dr. Nagender, any changes apart from this that we also routinely, do in cases where we have to split cisplatin between day 1 and day 8? And Dr. Nagender, are you there?
I'm there. So in our practice, sir, we always do the DTPA GFR upfront, because we know that creatinine, a patient who is having 5 years of age, who's having creatinine of 1.4, patient who's having a 64 years of age, creatinine of 1.4, and patient who's having 84 years of age, creatinine 1.4, all are not having a similar renal functions. So we'll always try to do DTPA GFR or the renogram and assess the GFR of both the kidneys together, and then take a call. I do agree. In my practice also, we'll divide the cisplatin dose in a patient who's cisplatin eligible in day 1 and day 8, and then take it forward, because this is much better tolerable. And other criteria, as Dr. Weber mentioned, I do agree. We'll follow this criteria and then take call accordingly.
Okay. And anything like if the GFR was 45, any takers for carboplatin use in neoadjuvant, Dr. Weber?
No, data is not sufficient for substituting cisplatin in carbon, especially in neoadjuvant.
Right.
I won't go
So
for
that is, yeah, that is a clear message. If the patient is operable and cisplatin ineligible, then probably the best treatment would be to go ahead with surgery upfront rather than trying carboplatin there. Although in clinics we are sometimes left in trouble where the patients have inoperable kind of tumors extended locally, although the response there also is doubtful. But that is the only situation we start with carboplatin first. And second question is actually the real world thing, that how many such patients do you actually tend to give neoadjuvant chemotherapy in first go? I mean, most of such patients practically to me would come after surgery, even at AIMS New Delhi. Most patients with a without any local invasion or without any node positivity on imaging mostly would get upfront surgery, and then we would decide on the adjuvant treatment. So, Dr. Chirag Desai, any comment on that?
So before 5 years, it was less than 10% of the patients, but now I think it is about 30-40% of the patients.
Wow, that means your urologists are truly, I mean, discussing all cases actually in
We
the
have been under the
multidisciplinary.
urologist for a long time. So
I think that is one important thing. Even that's, I mean, not even an Indian problem. That's globally that the
globally.
rates of neoadjuvant chemotherapy are lower, and these patients are generally 40 to 50% as they report, even from developed countries. So maybe we can move on the next slide, Archana, and can discuss a few points there. Next, I mean, this is clear. So we are done with that. So the patient here actually underwent trimodality bladder sparing treatment. Here, I think what we can discuss is what we use in the concurrent chemotherapy regimen. There are several options that have been discussed. I think I joined late and I was just on that slide when a lower dose gemcitabine and then cisplatin. There are reports of using 5-FU, carboplatin, all such. So, Dr. Vaibhav, what is your go-to regimen in patients who are eligible and ineligible, both? Like, if you plan to do a
Yeah,
CTRT.
theoretically speaking, yes, for those patients who are eligible, 5-FU cisplatin is there, which is a standard of care. Most of the patients actually, doctors go for that. For ineligible, it might be 5-FU mitomycin. But in my practice, in the setup which I have worked, I have hardly given this trimodal treatment to any of my patients. Most of the patients come through the neurosurgeon. We give neoadjuvant, and then just for the sake of discussion, yes, these are the two therapies which are being described. Honestly speaking, we are not, I don't have that much of experience in trimodality.
Okay, we do see patients who want to preserve knowing the complications of surgery that were clearly discussed by Dr. Desai, and I mean it's a big morbid surgery, and there are patients who would like to spare the bladder if at all possible, and and we do give CTRT. Like, it's not the first choice of treatment. Most of the patients would undergo, but there are good number of patients. So, Dr. Nagendra, any comments on that? Combination chemotherapy agent with radiotherapy?
Right, sir. So I do agree, sir, because the bladder surgery sometimes is quite mutilating, and majority of times it's consent based. Obviously, the patient is not willing for that. We cannot push. In that case, the trimodality of treatment is a viable option, in which we'll be using the concurrent protocol, as Dr. Weber mentioned, cisplatin based for patients who are cisplatin eligible, and those patients who are not ineligible, then other combination of 5-FU mitomycin also can be considered. So yes, there are a set of patients in which we will be using trimodality treatment for our patients.
Right. And any experience with the lower dose gemcitabine? That's a real low dose gemcitabine that was used in that trial. I think there are two regimens. One is a twice weekly and one is a weekly gemcitabine. Any experience with that?
So only those patients who are not fit for doublet chemotherapy. In that
So
case,
what do you prefer?
Right. So this is the way we take it. If the patient is fit enough for doublet chemotherapy, I'll be going for that. Otherwise, single agent gemcitabine, as you correctly mentioned, can use it in a lower dose and then continue the treatment with the concurrent chemo radiation.
Right. Any comments on that, Dr. Shak Desai?
So I have been giving carboplatin paclitaxel along with
Right.
radiation to a few patients.
Okay, that's like a cross.
Something like that, yeah.
Something like that. So what are the doses that you use in those regimen with radiotherapy? Is that like the same that was used in
Yes.
cross?
Same like cross. AUC 1.5 of carboplatin and 50 milligram per meter square of paclitaxel.
Okay, I think that's interesting. Taxane, we do use it as a second line of treatment in metastatic. Most of the patients who cannot take, so it is one of the effective agents. And although we generally tend to use, if not platinum, then it's usually either gemcitabine or carboplatin. So that's interesting. I think paclicarbo did show efficacy in the esophagus cross trial.
In the cross trial, we use, I'm sorry to interrupt, sir. In cross trial, we use the radiation of 41.4 gray along with Pacli 50 milligram per meter square and carboplatin AUC
1.5.
1.5, yeah.
So the point here is like in bladder. So what will be the dose of radiation when we are using the same cross protocol chemotherapy drugs? So whether the dose of radiation also
that is standard that they use around 50 grays is what they use for bladder. If is there any change in any other center, they can probably bring it up. But it's not 41.4. Yeah.
Okay.
Maybe Dr. Desai can answer it better because he has been using that paclicarbo protocol.
So 25 fractions, 50 gray.
Right.
Yeah.
Atul sir, Dr. Rajat Bajaj has also joined as panelist. So
okay.
He can also give his expert comments now.
Yeah. Hi, Rajat. We were just discussing about CTRT and chemo partners that you use with concurrent chemoradiation in urinary bladder cancer, where patients are either not willing for cystectomy or they are not eligible.
Yes.
So, any comment on that? What chemotherapy agents that you use?
Hi, Dr. Atul. Good evening, everyone. So, I've been listening to the discussion for the last 5 minutes. So, concurrent CTRT, if cisplatin eligible, certainly cisplatin plus 5-FU. If the PS is not that good, then probably cisplatin alone also. I have not used paclitaxel alone or paclitaxel carboplatin. I will vouch more for cisplatin, of course, if it is eligible, and if not, then 5-FU mitomycin, which I have used in a couple of patients.
Okay, yeah. But there is a wide variation actually in patients who are cisplatin ineligible and the chemo partners that we also saw in our own practice. So next, Archana. So this patient actually had a progression and then underwent radical cystectomy finally. And then there was a question like, what would have been your treatment if we can move further, that the patient underwent radical cystectomy and there was a good amount of disease, PT3 and 3 disease. So what would you consider as a further adjuvant therapy here? Maybe we can start with Rajat this time again. So this patient to begin with had a localized disease and did not opt for radical cystectomy. He underwent a trimodality treatment and then has a relapse recurrent disease. After 9 months, underwent cystectomy. And then we have this histopathology report showing PT3 and 3. There are no distant metastases. So what would be your adjuvant treatment here, if at all? Are you there, Dr. Rajat?
I think he is disconnected.
Okay, so we can start with Dr. Nagendra.
Right, sir. So in this type of scenario, just one more thing I want to add in before answering that whether the PET scan was done, whether there was any M1 site.
PET was done and there was no metastasis. So
no
PET CT, no distant metastasis.
Iliac is N3.
So the iliac were there, that's why it was N3. And In this type of scenario, sir, we can consider gemcitabine platinum-based chemotherapy as the adjuvant setting, or in this PT3 N3, because they are prone for recurrence and relapses. N3 status itself denotes that this patient may fail again. Although after giving concurrent chemoradiation or trimodality treatment also, the patient have relapsed within 9 months. We can consider systemic chemotherapy. We should do the molecular markers to take call accordingly.
Okay, what molecular markers do you think would help us? And does it change, like if the patient did receive cisplatin as a chemo partner during CTRT 9 months back?
Right. So is there any, like, our renal function test all are in well within the normal? Upfront it was 1.4 to begin with.
We assume it is still the same, that the clearance is around 50, so borderline candidate for cisplatin.
Right. So in that case, I think GemCis also can be considered, because we have not yet used gemcitabine-based doublet till now in the patient's journey. So that can be considered in this type of scenario in adjuvant setting.
Okay. And okay, Dr. Vaibhav, anything to change from your end?
I would prefer actually nivolumab in this case, because immunotherapy.
So my job is done. Probably Vaibhav and Dr. Vaibhav and Nagendra can take on for the rest of discussion, and I can sit silently and listen to both of them.
Actually, nivolumab, yeah, I would have preferred, because already chemotherapy he has received. I agree it was 9 months back, and cisplatin he has already received. Adding gem, yeah, there is some data. There is, in fact, one of the trials where single agent gem has also been effective. But this is an adjuvant setting. We must consider this is a curative setting. So if we are going for GemCis in this adjuvant point of kind of a thing, then we are actually depriving the patient of immunotherapy in nivolumab. Now, nivolumab, though I agree it has not shown the overall survival benefit as of now, but DFS data has been extended, and recent, I think, ESCO they read out, it was actually showing a good DFS. But still, since he has received chemotherapy, I would go for immuno here.
Okay, and the tiebreaker can be Dr. Desai, sir.
Yeah. So, we don't have any clear guideline. This is not truly the adjuvant setup. We can call it a pseudo-adjuvant setup. But nonetheless, I will be offering some sort of adjuvant systemic therapy, because he is at a high risk of developing further metastasis. Now, 9 months is a catch over here. If we look at the treatment of metastatic disease, if it was beyond 1 year of neoadjuvant or adjuvant systemic therapy, I would have repeated cisplatin-based therapy, but this is less than 1 year. So cisplatin-based therapy may not be useful for this patient. And so in that case, nivolumab is a good choice. I would want to look at the molecular markers, but I don't think we have any data of using any molecularly driven therapy as the adjuvant, or like in this case, pseudo-adjuvant therapy.
First line metastatic also there is no data.
Absolutely.
So any taker for GemCis followed by nivolumab, doing everything.
If it was beyond 1 year.
Right. I think that's exactly what we thought also. Like that is what I would also think, that patient was given cisplatin and there is a recurrence, and taking data from the Checkmate 274 trial, there was near doubling of the TFS time from 10 to 20 months. So it is effective agent. And all the immunotherapy in general has not been very, it's not been a gratifying kind of response. Only a few trials did show. One was avelumab maintenance after GemCis, and now we are seeing more and more trials. I think the recent one was in the metastatic first line. When you combine with GemCis nivolumab, it did show PFS benefit. And one is for the residual disease, as well as in those patients, it was for cisplatin ineligible who underwent upfront surgery were also included in the Checkmate 274. So, but although this patient is a recurrent disease, so would not fit either of the trials and is non-metastatic. So this is a unique situation where we are also desperate to use whatever we can. So nivolumab is one option, I agree. And has Rajat joined back? And he has, then we can also hear from.
Yes, sir. Yes, sir. He has joined.
Yeah. So Rajat, your
Hello.
take on.
Yes.
So do you remember the case that we were discussing?
Yes,
So
yes,
this is the same
yes.
patient, record, underwent radical cystectomy, and then there is this histopathology report, and we were just trying to discuss what would be kind of the best option for his adjuvant treatment.
Yes. So my points are that we, of course, are calling this as an adjuvant treatment, but we probably know that this is not the perfect adjuvant setting. That is number one. Number two is that this patient certainly requires something at this point in time, because otherwise patient is going to fail badly, and maybe even after some treatment here also there is going to be metastasis. But then certainly we would want to have him in the curative setting as much as we can. And between chemo and nivolumab, I think I would be tilted more in favor of immuno. It's a heavy nodal burden disease which he's got. Chemo with gemcitabine based therapy we can reserve for a later date if the patient has metastasis. And the data set that we have, of course, is not having OS benefit as of now, but the DFS benefit is still there, and we have used drugs in other subsites on the DFS benefit. So to me, I think nivolumab will be a better choice at this time.
Right. I think with the urinary bladder, I am quite convinced with DFS as an outcome. Like once the DFS event occurs, it is there are no n number of lines here in urothelial cancer that we can offer. It is ultimately platinum immunotherapy, probably taxane, and that's probably it. So the second event, the OS event, would actually rather occur pretty soon once we have a DFS event. So unlike hormone receptor positive breast cancer, where I feel DFS is uh, probably not a very good surrogate, here I think that is fine.
Sorry to
So I think
interrupt.
that
For
Just may I
metastatic,
add on a few things, Dr. Atul. I do agree, based on the data, nivolumab is a viable option. There's a doubling of
right.
DFS is there. In intentional T population, there was 75, nearly 74.9% benefit is there as compared to placebo. But the point here is, suppose we all know, we all agreed that there is no oral soil benefit. Point number one, DFS advantage is there. But suppose within 4 months on the first response assessment scan, again the patient fails, and again we start them on platinum-based doublet, and then avelumab maintenance will come into play. So whether we'll be exposing, all these questions are unanswered as of now. So these are the points which we have to keep in mind. And PDL1 greater than 1% only, the patients are going to get benefit. Suppose if we do the PDL1 percentage, if it is 0%, we are not sure that nivolumab is a viable option in this type of scenario too.
But I think in Checkmate 274, even the patients without PDL1 expression, those were two co-primary endpoints. And overall population, as well as those, there was better. I mean, the benefit was more in those. And correct me if I'm wrong. These were the two co-primary endpoints.
So,
and here our goal is to prevent a relapse. So while preventing a relapse, I generally believe in putting the best foot forward in whatever we have rather than keeping anything reserved. So if we can prevent a relapse, I mean, there is a extremely high risk that this patient will relapse, and ultimately the treatment options are limited. But thinking to reserve those options at a later stage, I would generally prefer at this time. I mean, other can also pitch in and tell their points. It is a unique situation. I know it's not a routine thing. That's why we brought this case.
And if I can have a comment, if the patient does have a relapse, very soon we will have two ADC, enfortumab as well as sacituzumab. Molecular-driven therapy, maybe FGFR positive, verdapitinib. So we will have drugs in future.
Yes, sir. And also the level of evidence is not that great for adjuvant chemo also. This we should not forget. We are extrapolating mostly, though there are many series as you also showed.
But the best evidence comes for nivolumab.
Yeah.
It is the cleanest adjuvant trial, if I can say. So I think we have another case to discuss. So do we wind up the any comments from Dr. Ashok sir on this case? Anything that you feel needs further discussion or anything? Sir is here or?
I think, sir, we can jump to the next case.
Okay.
Sir is not here, I think. So may I request Dr. Athira to kindly share her screen? Dr. Athira, are you sharing your screen?
Yeah, I'm sharing.
Okay.
Is my screen visible?
Not yet.
No, it is not. Ma'am, if you are not able to share, can you mail?
Okay.
So, sir, we have a question. Anyone can take this up, of course. So the question is that we have talked a lot about nivolumab and other therapies in muscle invasive bladder cancer, but they would like to understand for non-muscle invasive also. So what is the scope, and uh, if suppose it is being used before, then can we use it afterwards also? So if any one of you can throw light on the question.
Oh, I didn't get the question. Correct me if I'm wrong. If what was used in non-muscle invasive?
Immunotherapy, sir.
So the only agent that is approved there is pembrolizumab in a
Yes.
BCG resistant, despite BCG, if there is a recurrence and the patient is not willing for a cystectomy, the treatment there would be cystectomy, right? There are several treatments that are being tried there. Pembrolizumab is one approved agent, but the results are not all that great. So the first analysis showed that around 40% of the patients will be spared of a cystectomy and would be disease free after, I think, 1 year. But at 2 years, that percentage dropped to around 20%. So if you give pembrolizumab for 1 year, after 1 year, there will be 40% who will be disease free, but after another year or so, there'll be only 20%. So the failure rate there is around 80%. There are newer drugs being developed there. I think Johnson and Johnson did a trial with a TAR, some intravesical delivery with gemcitabine. So there is a catheter that is placed inside the bladder that keeps on releasing gemcitabine for a week or so. Along with that, they give their own PD-1 inhibitors, sertilimab or something. And there the results have been pretty good till now. That was the Sunrise trial. So the usage of PD-1 inhibitors in non-muscle invasive is not to a very great extent. It still remains, it should remain in the hands of urologists. And if there is a BCG resistant disease, then cystectomy is the currently right answer. If the patient is not fit enough or something, then all these modalities can be tried.
Yes, sir, thank you. Actually, we had the next question on Sunrise trial, so you have also thrown the light upon it. Any experience on the trial? So I think you have thrown the correct light on that trial also. So with this, I would just share my screen. So Dr. Athera, I hope my screen is visible. You can start presenting it.
Good evening, everyone. Thank you for the opportunity. I'm Dr. Adira, DRNB Super Specialty Resident at Max Saket. So my case is on metastatic bladder cancer. A 72-year-old male from Bangladesh. Comorbidities were he was diabetic, having chronic kidney disease, and he was a non-smoker. And in May 2019, he was diagnosed as having a early stage prostatic adenocarcinoma, and he underwent surgery, radical prostatectomy with bilateral lymph node dissection at Manipal Hospital, Bangalore. Then in November 2020, he underwent TURBT at Dhaka, and he underwent bilateral PCN and followed by antegrade DJ stenting. Next slide. So in 2020 to 2021, he was diagnosed as metastatic urothelial carcinoma, stage 4, as per EGCC 8th edition, and he was metastatic to bone, non-regional lymph nodes, and liver. So he completed 6 cycles of gemcitabine, day 1, day 8, and carboplatin-based therapy, and 4 weekly denosumab, and it was from December 2020 to April 2021. And he remained disease-free for 6 months. And in October 2021, he was deemed progressive. Next slide. So in 2021 to 2022, he was started on second-line pembrolizumab after discussion in the MDT at Medanda. And it was given 3 weekly, and the first cycle was October 2021. And he completed 10 cycles till May 2022, and in 17th of May 2022, the PET scan showed a progressive disease. It was oligoprogressive at perirectal lymph node, and the FNAC or cell block showed metastatic carcinoma. So in May to June, he received palliative RT 30 grade 10 fractions to pelvic node and mesorectal lymph nodes. Next slide. So he completed 14 cycles of pembrolizumab at Dhaka in 2022 September, and at September 2022, the PET scan showed a progressive disease, and there were no retrocaval pre-aortic and significant interval increase in the nodule in the left lower lobe. So he also had cough and dyspnea on exertion for 3 weeks. Next slide. So in the Vedanta, the PET-CT showed in September 2022, it revealed a stable thickening along the right posterolateral wall of urinary bladder with interval resolution of the previously seen pelvic lymphadenopathy, suggesting response to local RT. However, there is an interval appearance of hypermetabolic lymph nodes at new sites, that is at retrocaval and pre-aortic locations, along with significant interval increase in the irregular nodule in the lower lobe of left lung, suggesting of overall disease progression. So it was discussed at Medanda MDT, and the plan was to treat the lung lesion, non-regional lymph nodes with short course SBRT followed by systemic therapy. Next. But in September 2022, he came at Max Saket. So we did a biopsy from the left lower lobe lung nodule, and it showed non-small cell carcinoma, adenocarcinoma, and TTF1 was positive, and the pleural cytology was positive. So it was a metastatic adenocarcinoma lung. So we plan to deliver one fraction of one cycle of pemetrexed carboplatin with denosumab to continue, and meanwhile send NGS Foundation 1. So he received first cycle of pemetrexed carboplatin at Max on October 2022. Next. So the foundation report, which was reported in on 31st October 2022, showed a EGFR L861Q mutation, which was targetable by osimertinib. And next slide. And PDL1 was 0. And next slide. And the VAF was 35.2%. So he's a deemed metachronous triple malignancy with in 2020 he was diagnosed as early stage prostatic adenocarcinoma at Manipal Hospital, Bangalore, and in 2021 metastatic urothelial carcinoma at Medanda, Gurugram, and in 2022 a metastatic non-small cell adenocarcinoma EGFR L861Q mutant at Max Saket, and his PS1 and pain score was 0/10. Next slide. So the plan was to continue osimertinib, pembrolizumab, and denosumab till progression or unacceptable toxicity. And we did a CE-MRI in November 2022, which was normal. And he was continued on osimertinib, pembrolizumab, and denosumab. And in April 2023, the PET-CT showed decrease in size and FDG avidity of the lower lung lobe lesions, paraesophageal and retroperitoneal nodes, and the bladder mural thickening was also having shown a decrease in avidity and size, and pelvic lymph node and skeletal lesions was a new finding in the skin. So he received pelvis RT to the node-regional lymph nodes to right pelvis, 20 gray and 5 fractions, and it was completed in 18th of April 2023. So he was continued on pembrolizumab, and he had a secondary adrenal insufficiency which was treated, and he is now doing well on osimertinib, pembrolizumab, and denosumab. Thank you.
So, Nagendra sir and Atul sir, you can just proceed with the discussion. I think the case is interesting, all the metastatic, starting from prostate till the lung.
Right. So this patient, I think Atul sir is there.
Yeah, I'm here.
Okay, sir. So this patient actually was interesting because initially this patient was evaluated outside in Manipal Hospital, Bangalore, and he was diagnosed to be having early stage prostatic adenocarcinoma, adequately treated. And then when he came to Medanta, I diagnosed him that he's having a second malignancy, that is urothelial carcinoma, which was metastatic to begin with. Patient responded very well to gemcitabine and carboplatin-based chemotherapy, and then patient had a progression nearly after a year, and then patient was started on second-line pembrolizumab, which worked very well. Between patient was having progression, and then there was a suspicious lung lesion was there. So everyone thought that probably it can be secondary from the prostate adenocarcinoma or from the urinary bladder, but it was a speculated lesion. It was on the periphery, so we thought that it may be something else. We did a biopsy, but to our utter surprise, this patient was found to have a triple malignancy. It was a third malignancy. It was NSCLC adenocarcinoma, and peripheral cytology was also positive. And we have continued the patient on osimertinib based on the foundational NGS report. And this is the only combination which I thought that in which osimertinib can be given with immunotherapy. Otherwise, we all know that we never use, even if the PD-L1 is 100%, if the patient is having a targetable mutation, we'll never use immunotherapy. We'll go for osimertinib. But we have given pembrolizumab for this patient for urinary bladder, which was very much under control based on this, and patient has 28 pembrolizumab by now. And osimertinib also, initially in the tumor board also, we had a discussion that probably if we use pembrolizumab plus osimertinib is not a good option because there are chances of getting pneumonia, which is there. But this patient, luckily, is in good performance status and still taking these medications and coming from Dhaka every 3 monthly once and taking these medications there. So this was an interesting case of metachronous triple malignancy, prostate, urinary bladder, and lung cancer. So anything else we would have done other than this? Any thought process or any inputs on this case, sir?
So if I can,
yes, sir, please.
So there are a number of reports showing that combination of EGFR TKI and an immunotherapy drug, in fact, has a little higher chance of pneumonitis, which may be quite severe. So I'll be very careful in using this combination. We have the TMS data of TKI with carboplatin pemetrexed, and we have the trial of carbopemetrexed as well as osimertinib. We have some phase 2 data of pemetrexed in pre-treated urinary bladder cancer as well. So I would have gone for carboplatin pemetrexed and osimertinib for this patient.
Right. So in this patient, we have given first cycle of pemetrexed carboplatin, sir, and after which once the NGS reports have unfolded, in which the VAF was 35% of EGFR, which was significant. So we discussed in our molecular tumor board here. So everyone was telling that this was a category 1 recommendation by the foundational NGS also. So we started osimertinib in this scenario. But the point here is pembrolizumab we have not given for lung cancer We have given it for the urinary bladder, which was responding very well to the patient. And the prostate cancer was quiescent throughout the journey of the treatment, right?
Yeah.
So only two cancers which were active was the urinary bladder cancer and the lung cancer. Lung cancer, we are having a targetable mutation. For bladder, we have kept pembrolizumab. But the point here is, we are also having this thought process in our mind that patient may develop a severe pneumonitis. But in this patient is coming to OPD by walking, eating well, sleeping well, moving around. There is no admission for supportive care. And patient have completed nearly 28 cycles of pembrolizumab and osimertinib in the standard dose of 80 milligram once a day. So this was a utter surprise to us also, that we thought that if pneumonitis develops, we'll stop it immediately and we'll continue the osimertinib alone. But still, it is working well for this gentleman.
So I have one question on a lighter note. Is this osimertinib that Bangladeshi osimertinib that he's taking on?
No, sir. This was the Tagrisso, the AstraZeneca drug,
Tagrisso,
original
okay.
drug, because he was affordable. He have taken it by pocket. The pembrolizumab 28 injection itself, he afforded. Foundation NGS report, he afforded. He afforded Tagrisso also.
Yeah,
So,
actually, yeah, this is a fantastic case, and always our attitude of never say die in such cases where 3 malignancies are there. I have also come across such patients, but then these patients are fighters actually.
Yeah.
And if we persevere with them and never give up, then obviously such things are things. Really commendable that the way he's been treated. Only thing which I can add is somewhere down the line, if the progression, I think the last time the progression came was in the pelvic nodes and all, maybe it was related to bladder. So we might actually do well with a NGS of that bladder tumor as well. So in future, we might get some therapies, some targeted therapies whenever he progresses. That will be my addition.
Or maybe liquid
I would
biopsy.
be ready with enfortumab vedotin. This is, I think, the richest patient from Bangladesh, and
absolutely right, sir.
Maybe liquid biopsy.
Liquid biopsy, right? Correct. Right. So anything else we would have done, sir? Like, suppose you have faced these scenarios and any inputs, because this
patient
is
has done extremely well. So I think first, congratulations that whatever you did actually work. But I had a question, like, were you monitoring the pulmonary toxicity actively with some, like, patients would on and off staying in Delhi would develop cough on, especially in this season. So any cough or anything, would you do a CT or something, like listening to the discussion about pneumonitis, severe pneumonitis? So was it kind of, how many CTs did you end up doing during this time?
Right. So this patient, I told you that he was from Bangladesh resident. So he have taken this pembrolizumab in Bangladesh. He used to take those medications there. He used to take it from India. He wants only original drugs and like that. So he was like not the polluted environment of Delhi he was exposed to. He used to come for response assessment scan. So till more than 10 times he already come to India.
No pneumonitis anywhere.
No pneumonitis anywhere. And his pleural effusion also like vanished once the osimertinib started working. And it's PS1, as I mentioned, this is a PS1 throughout the journey, right? So this is an interesting scenario which happens. So that's why ultimate aim in advanced cancer is that we have to keep these patients as good as possible for as long as possible with the limitation of science. And it's not the drugs which conquers cancers, it's the knowledge which conquers cancer. This is a typical scenario. That's why Dr. Athar have kept the direction is much more important than speed. Most of us are going nowhere fast in oncology. So one more I want to highlight here. This is the patient's perspective, what he told, because he was diagnosed to be having prostate adenocarcinoma in Manipal Hospital, Bangalore. And second cancer, I diagnosed him in Medanta Medical Hospital. Then I moved from Medanta to Max Hospital, Saket. Then he also moved along with me. And then we diagnosed him that he's having lung cancer, which is the third primary. But the patient perspective is that he told Dr. Nagendra, please don't switch the hospital, otherwise I'll get the fourth cancer. So whenever he's switching the hospital, he's getting a new primary. This is what the patient's perception was there. It was interesting to listen from his mouth.
I think you should get to Manipal and he should get his prostate cancer back so that we can have many, many more options.
To keep him alive, I have to stay in Max now. Right.
No, interesting case. I mean, no right or wrong answer. Whatever proved was the right decision, and your decision proved right. So that was wonderful. Congrats for that.
Thank you, sir. It was working well for him. Ultimately, we want our patient to live longer and live better. Right. Thank you.
Yes. So any other points that has to be discussed? regarding the case. Otherwise, it's okay if we can just wind up this session. Those 2 cases have already been presented, but if there is anything else to be discussed, and I could see that there were 2 or 3 questions that I had already asked from the panelists. Okay, so yeah.
So only question which will be there, suppose disease progresses in this patient, the second patient, and what will be our options? Because we have already given immunotherapy, we have given TKI. So post osimertinib progression, how should we handle? Obviously, we have to do NGS from the progressive side. But what are the options? Should we go for ABCP in this type of scenario in a patient who have already received both the drugs? So we should be ready with our plan B now.
No, sure. So, I mean, biopsy of the metastatic site, new progressing site, and if possible, liquid biopsy. And if that is either bladder cancer or lung cancer, maybe carboplatin pemetrexed. And if it is bladder cancer, if the patient can procure, enfortumab will be the wonderful choice.
Perfect. Right. And if the progression is only for lung, sir, so whether we should go for ABCP or we should search for any actionable medication and take action accordingly, because post-osimertinib progression also we are seeing these days, and there are options like MET and C797S mutations. There are so many things which are possible.
We should look at the new mutation. That is first thing. If you don't find any mutation, if it is lung cancer for sure, then a Taxane will be a good choice. Maybe at this age, nab-paclitaxel will be a good choice.
Perfect. Right, sir.
Okay, so I would like to express my regards to Dr. Atul Batra and Dr. Nagendra Sharma, and thank you so much, Dr. Athira and Dr. Archana, for presenting such interesting cases. I think Dr. Vaid has already joined in between, so he won't be there for the closing remarks. So if there is nothing else, then I think we can close the session now.
Yeah.
And thank you so much to all the faculty for joining in time and ending up the session in time.
Thank you very much.
Thank you.
Thank you very much.
Thank you.